Aloha, everybody. I'm really glad to be with you all today and excited to speak with you. I wanted to say thank you to all of our sponsors today as well. And all these sponsors are listed on this slide. Okay, so we're going to start off today. We're going to talk about recognizing dementia, depression, and delirium. Then we're also going to talk about what doctors need to know from caregivers. And also we will cover what caregivers can do to help. Okay, let's start off with a reminder about what is dementia. Dementia is a problem with the brain. It's not functioning properly, and it's new. They weren't always like this. In fact, something changed quite dramatically. And so what this is this new onset cognitive decline is what this is. There are actually many different causes of cognitive decline, and dementia is the umbrella term. About 60 to 80% of dementia is due to Alzheimer's disease. There are also other causes, such as vascular dementia, which has to do with strokes and the like, and other things like Lewy body dementia, which is akin to Parkinson's disease, and frontal temporal lobe dementia, which is another neurodegenerative disease. So these are this sort of falls in the category of dementias. Then there's something separate that we kind of call the other dementias, which is sort of more treatable, so we say. So in other words, some cognitive changes are treatable. So this, as again, I'm just going to recap. This is categorized as dementia, and then this treatable dementias include things like depression. If we treat depression, we may see a reversal of cognitive changes. And then there's something called delirium, which are often due to medical illnesses like infections or different medications or changes in your body chemistries. In geriatrics, this is also known as the 3Ds: dementia, depression, and delirium. Okay, I'm going to, just to illustrate this a little bit, we're going to talk about the case of mom. Your mom is 80 years old. She's widowed 1 year ago, now living with you. You notice she's increasingly forgetful and increasingly dependent with shopping, meal prep, and medication management. She stopped gardening and reading in the past year. She had a fall and hip fracture 2 weeks ago, but now she's not eating well. She sleeps all day, she's restless at night, and she's not participating well in rehab efforts. And you want to know why she's not improving and what you can do about it. Does she have dementia, depression, or delirium? What should you tell the doctor? So, some helpful information. You need to give the doctor some information. So they need your story. And some of the helpful information they need is that you have to note the time course, the frequency, as well as any changes in behavior patterns. So, for example, we want to ask about, well, I often ask families or patients, well, how were things 1 year ago? What was she like? Like, say, last Thanksgiving, what was she doing during the last Thanksgiving that you had? What was 3 months ago like? What about 2 weeks ago? What did she do this morning? Did she say anything different this morning? Or is this something that you notice every single day? The other important thing to talk about is changes in behaviors. Has she stopped doing something that she usually enjoyed doing? Has her mood changed at all? Are her eating patterns different, eating more or eating less than usual? These are really important things to talk about, to describe to your physician. An important hallmark of dementia is that this is a gradual decline in function. So, for example, the daughter would notice she's more forgetful in the past year, right? Previously, she was able to do all of her activities of daily living, like bathing and dressing, all independently, no problem. You know, doctors often also ask about, well, what about things like shopping, transportation, and finances? Is there a change in that? Well, it turns out that her husband used to do this before, so there's not much change. She's still dependent. But it is important to ask these things because sometimes these change as well. Now, what about cooking? Is she cooking basic meals? Are they becoming less frequent, less fancy? Does it just consist of open a can of soup? Or is there more to the meal prep, right? Is she complaining of fatigue, napping a lot, watching more TV, doesn't leave the house anymore? And this has just been gradual. So this is really the hallmark of dementia, is this gradual decline in function. And it's so insidious, you don't even know it hit you. If you're not paying attention, you don't even realize that things have changed. And so that's why it's helpful to talk about what happened what was she like last year? What was she able to do? What were the types of things she was doing? An important hallmark of depression is that we observe episodic and recurrent problems with mood. So basically what we're talking about is, does she have a history in the past? Was she ever on antidepressants intermittently? Has this been a recurring problem in her lifetime? Right? So this is something that we've seen before, off and on. And perhaps her history says something like, well, she was on antidepressants since the death of her husband 1 year ago. Or perhaps in her history, you note that she takes sleeping pills about 3 times a week or has trouble with insomnia. Maybe she didn't even tell the doctor. She just does this on her own, right? It's important to know what the appetite was, because oftentimes with depression, appetite may go down, right? Or she may no longer be doing things that she used to enjoy, like reading books or gardening, or she's doing those things, but she's not finding enjoyment anymore. Feelings of despair and wishing she were dead, but many older adults are not really suicidal, but they just wish they were dead. Or maybe she's just been more irritable with you in the past few months. And irritability is an important sign of depression, even without feelings of suicidal ideation or feelings of depression. Just being more irritable is a red flag that we should probably dig a little deeper into. If you notice, depression, this is episodic and recurrent. It's not a sudden onset. And you should notice that there's something going on, and you should dig into the history about what she was, if she struggled with these types of mood problems over her lifetime. And then finally, the important hallmark of delirium is a sudden change is noticed. What do we mean by sudden change? We mean something like in the past few hours, past few days, or the past couple of weeks. So while she may have been more forgetful in the past year, you notice that there's just something that just changed in the last 3 days. Something is definitely different, and things that you may notice are things like being restless all night, trying to get out of bed, picking at the sheets, picking in the air, falling asleep while you're trying to talk to her. The sleep-wake cycle is topsy-turvy. She's talking crazy with some hallucinations or delusions, seeing things or hearing things that aren't there, believing things that aren't true, right? Rapid fluctuations in symptoms. So she may be alert one moment and then agitated another and then lethargic, half an hour later. So just rapid fluctuation is another hallmark of delirium. And for her, this is new behavior since her surgery. So something is different here, right? So she had sudden onset in the past couple hours to days. She's restless. She's talking a little crazy with hallucinations, and there's rapid fluctuation, and there's reversal of sleep-wake. That's what the hallmarks of delirium are. And if you see that, you have to speak up. In fact, if you see this, you need to talk to the doctor because there might be a medical problem that needs to be addressed right away. So it's important to tell your story. If you are seeing the doctor and, there's something wrong, something different about mom. Um, and the doctor needs to figure out, is this dementia, delirium, or depression? So that's why we need to have the full details. And don't be afraid to talk about the impact on you as a caregiver, because as a doctor is trying to help make a care plan to figure out how we can address this from a medical standpoint, there's a lot of support that needs to go into this as well, because you are the key to the treatment and management of these problems in order to maximize quality of life. Okay, so let's do a little deeper dive into delirium. What are the most common causes of delirium? Number one is actually medication side effects. Lots of medications have side effects. I always say there's no free ride, right? Well, you always have to weigh the risks and the benefits of medications. And sometimes if you started a new med in the past week and there's noticed a change with that, that's one of the things you need to suspect. Infections is another common cause of delirium, an onset of a urinary tract infection or pneumonia. And actually, we've seen COVID present this way as well, sudden onset of delirium, not necessarily even a fever or a cough, but delirium. That's enough to suspect and need to get a test for. Another common cause of delirium is abnormal labs. So if they show difficulty with the sodium level or the other blood chemistry levels or severe anemia, they can also cause problems with cognitive functioning. That's a sudden onset. Other medical illness can also trigger delirium, things like heart attacks or COPD exacerbations, lung, breathing difficulties, strokes, seizures, surgery, recent surgery, severe pain, poor nutrition or dehydration, like vitamin deficiencies and dehydration. When you get severely dehydrated, forgot to drink something, drink enough fluids, that can also precipitate delirium, and hydration can often solve the problem. Or urinary or bowel problems, namely, retention or, not being able to urinate or have a bowel movement, being severely constipated can also precipitate delirium. So yeah, these are the most common causes of delirium, with medication, infections, and normal labs being the top three. And so this is really like a medical emergency. It's kind of urgent. Doctors will look for the underlying medical condition. We'll do a thorough physical exam, probably order some lab tests, perhaps get some x-rays, and then take a close look at the medications they're on, see if there's anything new, anything changed. And of course, the way to reverse delirium is to treat the underlying cause. And also importantly, is we need to address and manage the behavioral disturbances. And as we talked about the last time with me, we have to try non-medication supportive approaches first. There are medications that can be used for severe disturbances like hallucinations and delusions and severe agitation that may harm themselves or others. But we need to be aware that many of these drugs can also have adverse side effects, so we really must weigh the risks and the benefits, and then minimize the use as much as possible by using those non-pharmacologic approaches to the maximum. So it's really important to address these distressing behaviors. That's one of the hallmarks of delirium, the distressing behaviors. If you recall, this is Maslow's hierarchy of basic human needs. So, as a review, we must first address those basic physical needs. If they're hungry, tired, cold, or hot, or thirsty, we need to take care of those first. Make sure that they're feeling safe, they're not having anxiety, fear, or depression. We have to consider their environment and make sure the environment is conducive to them feeling secure. Consider things like music therapy and gentle sensory stimulation. Body language and approach is very, very important to help them feel comfortable, to feel loved and accepted, and to address their feelings. And so there are a number of approaches, such as strategies like speaking slowly and calmly, acknowledging and nodding your head to show that you're listening, and to make an effort to show affection, to listen to their feelings and to address those. Um, really demonstrate respect, reassurance, provide redirection as needed, but above all, don't argue, because logic and normal reasoning doesn't work in this situation. In fact, it makes the situation worse. And the other thing is just provide some meaningful activities, provide some joy. They just have to provide some moments of joy. They are in the moment. They don't really know the past or the future. Those kinds of things can cause anxiety. So whatever you're doing now, make that moment count. Smile, reassurance, and and peacefulness. Okay. What else can you do? Well, as care providers, in addition to treating the underlying problem, we actually have to prevent complications as well. People whose brains aren't working properly often develop urinary incontinence because they don't exactly know when to toilet. And so being proactive and implementing a scheduled toileting program is something that we can do to prevent this kind of complications. Immobility and fall. So because of the delirium, their brain is not organized to realize that some things they do may be unsafe. They may be unsteady and try to get up. So we need to do what we can to prevent falls. And also, but that doesn't mean, tying them, restraining them, keeping them in their bed or things like that. But otherwise, we're going to have problems with immobility and weakness and deconditioning. So we need to avoid those physical restraints, make sure that we have somebody helping them to get up and move around and exercise, using physical therapy as much as possible, and then using just more time to encourage them to sit up and move their legs and arms, and do some limited physical therapy when they're not on physical therapy time. So really anticipating and trying to work on this proactively. Another big thing that happens with delirium is pressure ulcers. I mean, this is stuff that sneaks up on you, right? If somebody is just lethargic all the time and not getting up and moving, or they don't know to reposition themselves, they may wind up sitting on their okole for a prolonged period of time, causing a pressure points that causes a difficulty with circulation in the skin, and then causing that pressure ulcer and the skin under that the buttock area or the back or whatever the pressure is on to die, and then causing an ulcer, which actually can be quite painful. So this is and once you have a pressure ulcer, it takes a super long time to heal. So this is another thing where you just have to prevent. Just be mindful that these are common and should be preventable. Sleep disturbances are also common with delirium. And so needing to really implement a sleep protocol, avoid sedatives, maybe have a routine, and maybe do some warm compresses, a nice gentle massage at bedtime, dark lights, don't keep the lights on, that kind of thing. And just try to see, maybe put some nice soothing, calming music. Avoid sedatives if possible, because you can get that hangover effect. And then also perhaps maybe, uh, maybe just keep them awake during the day and not let them sleep all during the day, so that they have a better chance of sleeping at night. So that's called sleep hygiene. So being mindful of sleep disturbances. And then feeding. People who have delirium don't remember to eat, or they may have trouble with swallowing, forgetting how to swallow, and may have increased risk of aspiration or food going down the wrong pipe. They may also need assistance with feeding, so putting the food in front of them may not necessarily mean they will feed themselves. And so during this time of delirium, need to be prepared to provide that additional monitoring and assistance with feeding, as well as providing nutritional supplementation as necessary. So Yes, so families and caregivers can help provide that 24/7 supervision needed for their safety, especially in preventing falls, regular toileting, frequent repositioning to prevent those pressure ulcers, and feeding assistance to prevent dehydration and malnutrition during this very vulnerable time of delirium. It would be nice if, this would be really fast and temporary. Sometimes it is. If a person has a urinary tract infection and develops delirium, and you get on it right away and you get treated with an antibiotic, within a week, the delirium may go away, the person may be back to normal, and problem solved. And so all this uh, confusion and sudden change um, will just be taken care of within a week. However, sometimes we've observed that this may take a few weeks. And for a smaller subset, this may actually take a few months. And for some, it may even be longer than that, up to 6 months or longer than that. So this kind of support may be, and of course, the more severe the illness, if they've been hospitalized, if they had been in rehab for a prolonged period of time, these may mean that they may need this additional support and for prevention of complications for many months. And I think families need to be aware of that so that they can plan ahead. Okay, the other things that we could do is to prevent functional decline. We talked a little bit about that safety to prevent falls, but um, uh, we need to restore function in people with delirium. So reducing clutter and noise in the hospital, cognitive reconditioning, basically for staff to try to reorient the person during the hospital stay, if possible, but without agitating them. Because sometimes when you reorient people, they're really convinced that, today is Sunday and it's not, then arguing with them is just going to make them more agitated, and it doesn't really serve any purpose. So if you orient them, you can do it gently, but if it agitates them, you can stop that. Helping them to perform the ADLs as their delirium clears, match their performance to the ability, have them do more and more as they are able to, instead of just doing stuff for them because it's easier, or um, we need to provide a lot of education for the family, allow them to um, participate in the support, because this may actually be for a longer haul than realized, and that there is a family role in restoring function. It's not just the role of the doctors or the physical therapists or the occupational therapists or the folks in the healthcare system who are doing home care visits and nursing. But really, it is going to be a lot of education and support needed from the family side as well. And because delirium can persist, that increased ADL support needs to be provided and thought about for being provided for a much longer haul. Now, it would be, it's possible that the delirium and the ADL support needs may resolve more quickly. And if that's so, then that's fantastic. But it's important to plan ahead. So yeah, so what can family and caregivers do? They must reinforce and restore function beyond PT and OT. So don't just rely on them. The family should be there to provide frequent orientation cues, make sure they got the glasses and the hearing aids, early mobilization, get them out of bed as soon as possible, adequate socialization. All this will help with recovery and getting them back to as best as possible. And I said before, ADL support may be required for the long haul. Okay, so this is just to flesh out a little bit of what happened to Mom, right? She had a fall and a hip fracture 2 weeks ago, right? But she's not eating well. She sleeps all day. She's restless at night and not participating well in rehab efforts. So now that you understand what delirium is, you see, this is a sudden onset. It was 2 weeks ago. She's having disturbances with eating behaviors, um, and she's not participating well in rehab. So she does meet the criteria for delirium. So what do we do? Well, it turns out that after hip fracture, she developed a urinary tract infection. And, she was treated with antibiotics. And so that's really important, treating the underlying condition and then let the body heal. But then important part of the treatment is that the family is enlisted to take turns visiting more frequently, to provide more reassurance, to provide socialization and supervision. And the family is enlisted to help with feeding, falls prevention, and incontinence needs as well. This type of support should occur in the hospital or rehab and in the community as well. Okay, let's do a little deeper dive into depression. So, what do the doctors ask about when we talk about depression? Generally speaking, the criteria for depression is that these are symptoms that last more than 2 weeks, right? It's this constant feeling of sadness, feeling blue, and that there's this loss of interest in favorite activities. They may also have feelings of feeling nervous, guilty, very tired, hard to make choices. There may be changes in appetite and weight, either up or down. Thoughts of death or suicide and irritability are the hallmarks for that. And like I said before, you know, uh, that lifetime history, recurrence, intermittent is something we look out for in the history to see that this is likely to be depression. The doctor will also want to rule out things like thyroid disease, vitamin B12 deficiency, anemia, medication side effects, drugs or alcohol, or whether this is just normal grief or bereavement. As medicines and thyroid treatments or changes in medications can also be used to improve to improve the situation as well. Okay, so how is depression treated? Oftentimes with medication, such as antidepressants. There are many different types of medications, and I always say there's no free rides, and every medication has different side effects, and usually based on what we're observing in the behaviors, we basically choose medications based on their side effect profile to make it more to work for them in more than one way. So behavior therapy is also important. So medications isn't the only answer to treatment of depression. It's really important to address the environment as well, because it may take a long time to find the right medicine or therapy. Antidepressants typically take 4 to 6 weeks to kick in. So what are you going to do in the meantime, right? You can't be miserable for just 4 to 6 weeks. We got to do something right away, right? So if we can do things like regular aerobic exercises or plan and schedule enjoyable experiences just to change their moods from the outside in. There's electro-convulsive therapy, that's ECT, that's pretty drastic, only if it's so severe that they're suicidal and nothing else is working and needs to be immediate. But it is there as an option. We don't use it very often, but actually it's not as bad as it used to be. I think back decades ago, it used to be much more drastic, but now there's different treatments that are better. And prompt treatment is important to save a patient's life and to improve their quality of health. So how can the family help? Right? Medicine can only go so far. The support from the family and friends makes a huge difference, right? And we have to make sure your family member or your friend gets help, and that we have to make sure that they take their medications regularly. And we also have to think about helping them and noticing if there are any side effects that come up. Because if there are, then we want to adjust the medications to have fewer side effects and adjust that side effect profile. Also, make sure they get regular checkups. Tell them that depression is nobody's fault, and don't blame or make them feel guilty or anything like that. And of course, it's okay to ask them if they have thoughts of suicide. It's not going to cause them to be suicidal. It'll just help them express it a little bit more easily and get them the help that they need. Right? If they're ever thinking about it already, then at least you know about it. So take them to the emergency room if they have thoughts of suicide. So let's just think a little bit about what happens with mom with depression. So let's look at the story in more detail. She was widowed a year ago, now living with you. So that makes you think, well, maybe there's some bereavement going on, right? But you notice she's increasingly forgetful, increasingly dependent with shopping, meal prep, med management. She has a history of depression in the past. She says that she wishes she were dead. She stopped doing the things she enjoyed and she's more irritable. So she also meets criteria for depression based on a screening tool, which the doctor can perform. Doctors rule out first, we always have to rule out reversible causes. So we rule out medication side effects, thyroid problems, vitamin problems, things like that. Replace things if need be. Consider bereavement support if they're still expressing sadness about the death of a loved one with grief. Consider the trial of antidepressants, and then work with the family to consider changes to environment. Sometimes we need to change the living situation to provide more social stimulation. Maybe they're just at home alone all the time, and maybe we need to have them maybe move in with somebody for a little while, or attend a program, or start getting volunteers to call or check in on them, or have other families or neighbors to check in on them. So really need to change that environment and living situation to provide more encouragement and social stimulation. And then enlist the family and friends to visit more often and to plan enjoyable activities. So this requires the whole team coming together and being creative and thinking about how we can support the emotional needs while we're waiting for the medications to kick in. And finally, I'm going to talk a little bit about the evaluation of dementia. Dementia, as we talked about, what we notice with dementia, the hallmark is that gradual decline of cognitive function. That means the brain is gradually being less and less able to do the things that help them function independently and to function on their own. So we do ask, since it's a lot about not just memory, but about function, the doctor will ask about the tasks that are required for independence. These are the independent activities of daily living, the IADLs. So yeah, what were they like? What was mom like before with managing her money, grocery shopping, doing housework at home, cooking, right? Preparing meals, laundry, medicine, telephone use, being able to communicate with the outside world and get appointments set up, coordinating transportation and just getting around outside. So these are the skills required to live independently. And then as dementia progresses, you may also lose what we call activities of daily living. These are the basic tasks of functioning that includes basically waking up, getting out of bed, going to the bathroom, washing up, getting breakfast, getting dressed, and getting around inside the house. So these are the basic activities of daily living, and sometimes people may develop difficulty with that. So those are the important functional questions that we will be asking caregivers about. So you should come prepared with these answers and what you noticed about these types, their skills in being able to do this. The other aspect of dementia that the doctors will ask you about is about their behaviors. Dementia behaviors can occur throughout the entire spectrum of dementia, from early stage dementia all the way to late stage. And because it's so common, we will ask about all these things. We will ask about verbally abusive types of behaviors like screaming, or anxious or repetitive questions, or more physical type things like throwing and hitting, or restless and tapping. So these, if you notice any of these behaviors, you need to share them with the doctor. And what does the doctor do with evaluation of dementia? Well, we'll do a thorough physical exam, particularly neurologic exam, do a cognitive exam as well to see where we're at. And then, of course, once we get a baseline, we can follow them every 6 months or so to see if that's declining or remaining the same or improving. There's lab testing to make sure we don't have what we call those reversible causes of dementia. And then possible brain imaging if we suspect things like strokes or normal pressure hydrocephalus or things like that. So how is dementia treated? Well, we wish there was a magic pill, but the current medications have limited effectiveness. There is currently no cure. Today's FDA-approved medications cannot stop the damage and the death of brain cells, but may only stabilize the symptoms for a limited time. Basically what it does, it just helps to regulate the brain chemicals, and it just basically holds up the neurochemicals as best as possible. And so at best, it may slow decline or improve behaviors, but it's not going to stop the damage and the death of brain cells. That's kind of where we are right now. And those FDA-approved dementia medications fall in two categories: the cholinesterase inhibitors, and you've probably heard of the common ones, right? The Aricept, Exelon, Razodime. Those are the ones that are usually used for mild to moderate dementia. And then memantine or Namenda, which is often used for moderate to advanced dementia. And sometimes they're used together as well. And what else do we do? Because there's no free rides with medications, and medications, remember, I talked about, is one of the number one causes of delirium, right? We want to avoid or minimize medications that can worsen cognitive function. And so a whole bunch of geriatricians and pharmacists put together what's called the Beers criteria list. And this is an explicit list of potentially inappropriate medications that are best avoided for older patients because their risk profile is worse than their benefit profile. And so there is a whole host. Actually, there's you go to a website and look up Beers criteria. There's health and aging, older adults med list that adults should avoid. And there's also fact sheets, and you can take a look at those lists. And you can review them with your doctor or your pharmacist if you are concerned with any of the medications you're on. But most of the time, hopefully they've thought about that risk to benefit ratio before starting anybody on those meds. And I like to go through this because if there's any ways to substitute medications, like an alternate antibiotic or an alternate blood pressure medicine that has less risk for delirium and dementia and cognitive dysfunction, then I would rather use those alternate drugs. Or non-pharmacologic strategies, even better. And as mentioned before, dementia behaviors are very, very common. And so we really have to do a lot of caregiver training and support, right? Teach about the dementia approach, how to modify the environment, providing activities that are meaningful and failure-free so as not to produce frustration. A lot of music therapy and sensory stimulation have been shown to be the most effective non-pharmacologic strategies for helping patients feel more peaceful and comfortable and happy, and not as distressed and anxious. The other really, really important thing about dementia planning is that this is really for the long haul. This is a progressive neurological deterioration that happens. And so things generally will progress. And so we have to really plan for the future and provide that safety net. Planning for the long haul, planning for 3, 6, 9, 10 years, 12 years out even, because cognitive decline, like I said before, occurs gradually, slowly, over time. So starting to talk about driving safety and discuss driving retirement early, even way before the time they need to stop driving. So at least the idea is introduced to them and they can kind of get used to the idea that at some point we may need to get a chauffeur. And just as you retire from work, it's okay to retire from driving. There are others who can help. providing that safety net in terms of, are you going to be able to live in this house as your dementia progresses? Will it be safe? Will we need to consider changes in household and living situations down the road? At what point? Based on the cognitive tests that you have now and what we estimate for the progression may be, we may need to think about moving in 3 years and 6 years, and we can plan ahead for that. Medication safety is really important. Oftentimes people with dementia don't remember if they took their medication, or if they take a double dose, or they may forget to take, and may wind up with underdosing or overdosing and wind up in the hospital. In fact, that's kind of one of the more common ways to present with dementia, is to wind up with a medication safety problem. People with dementia are also at risk for abuse and neglect. Their behaviors may be very, very frustrating, and as loving and well-intentioned as families are, sometimes they can't help get frustrated and yell or strike out or walk away and not provide what's needed at the time because it's just too difficult or too frustrating. Or if they are living alone, self-neglect is very, very common as well, and nobody is even aware that that's happening. So it's important to be aware that this may happen. And while we want to provide as much independence as possible, we really need to be aware of these kinds of risks. Because this is a long haul problem, we have to do financial planning and capacity. Think about the capacity. Are they able to make decisions down the road? And are there decisions they need to make now because down the road we anticipate that they're not going to be able to in a few years? And of course, also planning for advanced healthcare directives, right? In the event that right now they can express what their wishes are, maybe down the road they may not. So it would save a lot of angst and pain if we had talked about it while they stay able to express what's important to them. So yeah, it's really important to talk about planning for the future because this is a long haul problem. I want to encourage caregivers that you don't have to do this on your own. There are lots of supports in the community, like the Alzheimer's Association. There's case management agencies, there's adult daycare centers, there's respite care, there's care homes, there's nursing homes. And those things are all available if needed. These are just some of the contact numbers for Alzheimer's Association Aloha chapter. And if you run into problems in the middle of the night at 1 a.m, they have a 24/7 hotline, right? Catholic Charities Hawaii, Diane Terada can probably share more about that with you. And they do have a senior services intake line, and they have a lot of programs and services for you. There's the Hawaii Aging and Disability Resource Centers, also with a toll-free number. Okay, so let's talk a little bit about what we did with Mom here, right? So we talked about that she was widowed a year ago, living with you, increasingly forgetful, increasingly dependent. What we notice is this gradual decline in function. And her cognitive screening is positive, which means that she screened positive for dementia. So the doctor completes a comprehensive medical evaluation, changes whatever medicines they need to do, and make sure we optimize everything. But it's also important to discuss safety, like driving and medication safety, environment, the poor safety awareness. Sometimes folks, they may try to climb up that mango tree or reach up on the ladder to get to the dishes on the top shelf or things like that. So meeting basic needs and discussing safety in the home and prevention of basically disasters and emergencies. And that the family should get together and develop a plan for future financial health and housing and caregiving needs as well. I mean, the families are usually busy, right? And they're very complex, and there's kids, and then there's grandkids, and there's aunts and uncles, or maybe there aren't any, right? And so we really need to have a plan to develop now for the long range, 3, 6, and 9 years down the road, so that this is not a surprise, because care does cost money. And of course, needing to think about caregiver support as well, because this is a hard time to go through, and they need all the support that they can get. So in summary, it's important to recognize the difference between dementia, depression, and delirium. Dementia being a gradual decline, depression being something that may have occurred in their lifetime as recurring and intermittent. And delirium is something that is acute onset that happens in the last few hours and days or weeks and requires a physician evaluation to treat the underlying cause. All of these require a lot of partnership with the healthcare providers to get a proper diagnosis, to get prompt attention, and to get the proper support. And that, it's not all on the healthcare system or the doctors. It's your support of older adults with the 3Ds, dementia, depression, or delirium, is important to maintain and to achieve maximal quality of life. So together, right, we can work towards a better story. This is a picture of my family. That's my mom, that's my dad, and this is the 4 kids, all 4 of us. This was last Christmas. We celebrated together. This has been a really rough year. His dementia had progressed, and it was very hard caregiving, and all 4 kids, we all pitched in, and we worked with the supports in the community and hospice and everything, and he passed away in September. And so, this has all come very real to life now for me in recent months. But yes, we were able to achieve, we were able to get the help and support for my mom, for our family, for my dad, and we were able to get as best quality of life as we could. And it took a lot of planning and a lot of support, but going in mindful and aware of all of these things it makes a huge difference. And so, yeah, so it takes a whole team. We need your story. We need to work together, and we can work towards a better story. So with that, I'm going to say thank you very much.